Okay, welcome everyone. Unfortunately, there was a problem with the neurology review session recording from yesterday from the live WebEx, so I am re-recording it for those of you who missed it or would like to review. So we are going to once again go through neurology, musculoskeletal, psychosocial, and endocrine review. And again, if you weren't in the class, I know the original schedule had session 4 going with just endocrine, GI, renal, hematology. But in going through some of the material, endocrine, renal, GI, all that take up 20% of the test, and it's quite a bit of information to go through in 2 hours. And as opposed to that, neurology, musculoskeletal, and psych are about 15% and a little less percentage of time. So in order to spend as much time on everything that I think it deserves, and I wanted to spread it out and kind of rearrange. So this week we're going to do neurology, musculoskeletal, psych, and add endocrine onto the end because it kind of flows with it. There's a lot of the endocrine system that's in the brain. And then next week we're going to pick up with GI and renal and hematology and skin. So that'll be next Tuesday. But for today, let's start with neurology. So for the pediatric CCRN test plan, neurology, musculoskeletal, and psych make up 15% of the questions. So out of the 150 questions, that's going to be 22 to 23. The majority of that is going to be neurology, and then probably a couple questions for musculoskeletal, and then psych. So if you're ranking them, it's really neurology, then psych, then musculoskeletal. This is the test plan from the CCRN handbook, so you can see all the different things that are covered. And we'll try to hit as many of them or the important ones as we can today. Okay, so first, just starting off with some anatomy and physiology like we've done with the other sections. This is a picture of the brain and kind of the different parts. So you've got the cerebrum here, the big main part. This is what you think of as the brain, the hemispheres. The temporal lobe, occipital lobe, frontal lobe, all of that. And so it's what makes up gray matter. And then coming down, you have the corpus callosum. That's the connection, kind of a bundle of nerve between the brain, the hemispheres to connect them. And then you've got more internally, you've got the ventricles, the thalamus, hypothalamus, pituitary glands. Coming down here, you get to the brainstem, and you have the midbrain, pons, and the medulla oblongata leading down into the spinal cord. And then here in the back, underneath, you've got the cerebellum. So all around the outside, you're going to have meninges, so that's the lining of the brain and spinal cord that protects it. And on the very outermost part, you'll have the skull. You're not going to get probably tested on the makeup of the brain itself. They're not going to point to a section and ask you what it is, but it kind of helps to kind of orient yourself and have an idea of where things are. All right, so the meninges. There's 3 different layers. These are the layers that protect the brain and spinal cord, and there's 3 of them, and it kind of helps to think of the acronym PAD, PAD. They pad the brain, they protect it. So P is the innermost part, closest to the brain. It's the pia mater. It's very vascular in nature. In the middle is the arachnoid. So this is a feathery layer that kind of is between the pia and the dura. And outermost to that is the dura mater. So this is right next to the skull. It's very tough and helps protect the brain right before you get to the bone. The subarachnoid space we talk about a lot, and it's pretty important in the neurologic system. It's in between the arachnoid and the pia layers, and it's important because it's where the cerebrospinal fluid is. So CSF, we'll go over that in a minute, but it's produced in the ventricles. It kind of works its way out and then moves freely through the subarachnoid space, and that's where it's surrounding the brain and spinal cord in that area. So here's cerebrospinal fluid. Again, it's first produced in the choroid plexus of the lateral ventricle, so kind of in these 2 large ones that you see on the side. From there, it travels into the third ventricle that's right there in the middle and a little bit below. And from the third ventricle comes down this central aqueduct into the fourth ventricle. From the fourth ventricle, that's where it can get out into the subarachnoid space, bathe the brain and the spinal cord all over. I'm going to go, well, this is just a list of the cranial nerves. Again, I don't think you're going to be asked specifically about these and what they do, but just as a reminder, these are what the cranial nerves are. And the cranial sutures. So, as you know, the bones of the skull come together, and where they form, where they meet, are called suture lines. So this is a newborn skull. You can see the different suture lines. And the important thing to remember here is the fontanelle. So you have, first of all, the anterior fontanelle. That closes around 12 to 18 months of age. And then back here, the posterior fontanelle, which usually closes at 2 months or so of age. When you have a lot of swelling in the brain or pressure, increased ICP, these suture lines and fontanelles can open back up to the age of about 12. But in a newborn normal baby, anterior closes by 18 months and the posterior by 2 months. So what's some important things to remember for neurology for peds versus adults? How is their structure different? So first of all, they're going to have a relatively larger head with some weaker neck muscles. So that means they're kind of like bobbleheads. They've got these big old heads. Neck muscles aren't quite there to support it, which means when trauma can happen, they're much more likely to have that head kind of, move quickly, and, in response to changes in velocity. It can kind of get thrown around and damaged more easily. And that neck muscle is not able to compensate like it would for an adult. In addition, especially the younger they are, the thinner their cranial bones are going to be. So they're kind of not as thick to protect the brain itself. They have less myelinated nerves that are easily injured. So I could have had a slide about this, but each functional cell of the brain is called a neuron, right? So you have that neuron, the brain cell, and then out from it, it has what are called dendrites, which are the little fibers that pick up signals and bring it into the cell body itself. And then you have one long axon that then leaves the cell and takes a signal to somewhere else. So either another neuron or to a muscle cell or something like that. So that axon, that long, piece of nerve carrying signal away from the cell, that's usually covered in what's called a myelin sheath, and that protects it. It makes up the white matter of your brain. But as kids develop, that myelin sheath grows, and so when they're very little, they have less myelinated nerves, which basically means they're less protected, more easily injured. And then lastly, again, you have the open fontanelles in infants, and that's, it makes for less protection, right? Because there's not a hard skull over that part of the brain, but it also kind of is a pop-off valve for pressure. So if infants are injured, it gives a little more give and take for the brain to swell and things like that without causing more damage from a fixed skull structure. Okay, so moving on into the physiology of the brain, so the autonomic nervous system. So you've got kind of two competing systems that are going to regulate your nervous system, your bodily functions, kind of at a basic automatic level. So first is the parasympathetic nervous system. And this is your rest and digest. So this is where your body's at rest, you're digesting food, and all of these things happen. You have vagal stimulation, so your heartbeat slows. Think about how after you eat a big meal, you want to take a nap. That's your parasympathetic nervous system. Moving on to your sympathetic nervous system, this is your fight or flight reflex. This is what, you release epinephrine, norepinephrine, your heart rate goes up. Whenever your sympathetic nervous system is stimulated, that's when you're going to go into that fight or flight and see all these symptoms. Cerebral metabolism. So the brain takes up a lot of energy, a lot of oxygen. It actually uses 20% of the oxygen. It receives 20% of the cardiac output from your heart, and uses a lot of oxygen, and it requires a constant oxygen delivery. So the thing about the brain is, as opposed to other parts of your body and muscles that can use anaerobic metabolism, so when they run out of oxygen and glucose or oxygen, they can switch over to anaerobic metabolism and burn up other sources of fuel without the use of oxygen, and that builds, causes lactic acid buildup and all that in your muscles. The brain can't do that. It has to have oxygen for metabolism. It can't revert to those other backup anaerobic processes. So you have to have oxygen for your brain in order for it to run. And it also needs glucose, and it needs a constant, consistent delivery of glucose. The brain does not like too much or too little. It really doesn't do well in those environments, and it can cause a lack of oxygen or a lack of glucose can lead to some brain damage. All right, so cerebral blood flow. It's determined by a lot of different things, how well the blood flows through the brain. It's like any other organ. So it's going to be determined, first of all, by the size of those arteries, whether or not they're constricted or dilated, what your mean arterial pressure is, so your blood pressure pushing that blood up into your brain, and then the viscosity of the blood, so how thick it is. And all this should sound familiar. It's similar to, again, how it goes through other systems, cardiac, pulmonary, all of that. And it's going to vary with age. But the big thing to remember for this is cerebral perfusion pressure, because you probably will see questions about it, and it's an important concept to remember. So cerebral perfusion pressure is basically your MAP minus your ICP. So the MAP from your blood pressure minus whatever your intracranial pressure is in your head. So in children, they should have at least 50 on their CPP to have adequate perfusion to their brain, and adolescents to adults are going to need 60 and above. Okay, so let's look at a little bit about the relationship between intracranial pressure and volume in the brain. So there's this Monro-Kellie hypothesis, but it basically says the brain is made up of three parts. There are three things in the brain, and how these things increase or decrease affects the pressure in the brain and the volume. So you have a rigid skull that's kind of keeping these things in place. A rigid, if you're not an infant with those fontanelles. So you have your brain itself that's taking up a lot of volume. You have your CSF, that liquid that's cushioning the brain, bathing the brain, and then you have your blood. Those are the three things that are making up the space inside your head. So if any one of those goes up, the pressure is going to go up because it doesn't have anywhere to go, right? Your head is rigid, your skull is rigid. Luckily, again, for infants, they have those fontanelles that can kind of expand, and that's why sometimes we might need to do a craniectomy to take out part of the skull to allow for it to expand. But if any one of these things change, it's going to change the pressure inside your brain. Okay, intracranial dynamics, hemodynamics. So let's talk about ICP. A normal ICP is going to be, intracranial pressure is going to be 5 to 15 millimeters of mercury. Anything that's consistently above 20 is considered an increased ICP. And again, this is your cerebral perfusion pressure, MAP minus ICP. So above 50 in kids, above 60 in adults. So what are some signs and symptoms of increased ICP? So you're going to see changes in their level of consciousness. They might start to be more lethargic and irritable. You're going to see a tense and bulging fontanelle if it's an infant. If it happens slowly over time, especially with babies, you could see an increased head circumference because that's slowly been pushing out their head, which is very malleable, still developing, and it can cause an increase in their head circumference. They can have emesis, especially projectile vomiting, and then a high-pitched neuro-y cry. One important concept to remember is Cushing's triad. As that ICP increases, as it starts becoming a problem, you're going to see these things. And I know I have them in 4 points here, but it's 3 basic things. So, and you're going to look for these 3 together. So first is hypertension along with a widened pulse pressure. So you're going to see a higher systolic blood pressure, but that diastolic is going to be the same or lower. So you're going to see a wide pulse pressure, but hypertension, along with that bradycardia. And sometimes leading up to this, you might be seeing them be tachycardic, and then, you see all of a sudden bradycardia on the screen. And then lastly, either abnormal respirations or apnea, some kind of alteration in the respiratory pattern. So that's Cushing's triad. That's an important thing to remember and to memorize if you don't already know it. Next, a late sign of increased ICP is going to be papilledema, and this is swelling on the optic nerve. You need an otoscope to see it, so it's not usually part of our nursing assessment, but it is a sign of increased ICP. And then posturing. So there's 2 types of posturing: decorticate posturing, which means there's some kind of cerebral dysfunction, and then decerebrate posturing is progressing on from that, and that means there's some problem in your midbrain inside your brainstem. So these are pictures of that. I remember it: decorticate, pretend you're grabbing a cord. So that's inward posturing, and then decerebrate is, an outward pronation of the hands. And, I've heard it said that a kid looks like they're trying to fly away, angel to heaven. So decerebrate posturing, again, this indicates a problem in the brainstem, and it's a more severe problem or sign. All right, so what are you going to do to manage increased ICP? So again, your overall goal is to maintain an effective cerebral perfusion pressure. You want to make sure you can get the brain perfused with that oxygen and glucose that it needs. So first, you're going to support oxygenation and ventilation, support their systemic perfusion, maybe increasing their overall blood pressure. That's going to increase the MAP, so that's one part of the equation. You're going to try to control and decrease their ICP as much as you can. So initiate some measures to decrease it, and that along with that, you need to know what it is. So you might need to place some things to monitor your ICP. You're going to want to preserve cerebral function as much as possible and try to prevent secondary injury, because whatever's causing that increased ICP, it could be some kind of trauma in the head, but the worse the ICP gets, the more injury that's going to cause, and you want to try to prevent increasing that level of injury as much as possible. So one thing you can do is mild hyperventilation. So CO2 in the blood is it can cause vasoconstriction. So you can get cerebral vasoconstriction in response to a decreased CO2. So hyperventilating a little bit, blowing off CO2 is going to vasoconstrict, make those arterioles smaller, which is going to decrease that volume in the brain. Diuretics like mannitol or Lasix can reduce the cerebral blood volume, because it's going to draw off that fluid that might be causing edema in the brain and allowing them to pee it out. Hypertonic saline is, again, another thing to increase the osmolarity of the blood, draw that fluid out of the brain. You can drain some CSF using an EVD device. And then sedation, like barbiturates or the benzos that we use, something to decrease their stimulation, which should also decrease their ICP. All right, so what are some nursing interventions that you can do in the moment? So you're going to want to increase their head of bed, at least probably 30 degrees, maybe higher. And this is just to help that cerebral venous drainage come back out. And along with that, you're going to want to maintain their head midline. That helps with venous drainage and CSF movement and drainage. You may or may not restrict their fluids. It just depends what the cause is. And then you're going to want to cluster their care and limit stimulation as much as possible, because stimulation and irritation is just going to make their ICP go up. All right, so how can you monitor their ICP? There's several different devices and systems you can use, and they're kind of named based on where the end of their catheter or monitoring device is. So the one we see a lot is an intraventricular device. So it's placed through the skull, through the brain tissue, and all the way inside those lateral ventricles. It's considered the gold standard of monitoring, and the most accurate because it's the most central. It takes a lot of skill to place one of these. This is what we call our EVDs or something like that, an externalized ventricular device. These have a higher risk of infection because they are so far into the brain and so invasive, but they allow for drainage of CSF. We can also instill medications into it and send samples to the lab if we need to check, cultures or something, cell counts and things like that. The other one that we use most common is a subarachnoid bolt. So that's just a bolt that goes straight into that subarachnoid space. Some go into the parenchyma or the brain tissue itself. And these allow for monitoring. They're usually faster to insert than an EVD because you can be quicker about it. You don't have to be as concerned with getting into, a very specific space. So they can be quicker. And sometimes, depending on the amount of pressure in the brain, those ventricles might be collapsed. You may not be able to get an EVD in. So this is a good alternative. They're a little bit lower risk for infection because they're not so central, but they still carry a risk for infection as well. But you can't drain CSF from them, and they're a little more likely to be blocked and kind of lose functionality as they're in for longer periods of time. All right, so hydrocephalus. This is an excess of cerebrospinal fluid. There's a couple of different kinds. There's communicating versus non-communicating. So a communicating one, again, means there is movement of CSF as normal. There's just, the problem here is a decreased absorption of CSF or some blockage that's outside of the ventricular system. So the CSF is still able to move around from, the ventricles into the subarachnoid space. It's just not getting reabsorbed like it should. And then non-communicating is an obstruction within the ventricular system. So that's something that's blocking the CSF from getting out of the ventricles itself, causing the ventricles to get bigger and bigger. I think I I forgot to mention when we were talking about CSF. The body makes about, in an adult, about 500 mLs of CSF a day. And normally that goes through those ventricle systems, like I mentioned, into the subarachnoid space, and it's reabsorbed in the arachnoid village. But so that's why, one of the problems can be it's not being reabsorbed like it should be, and another problem is it's getting blocked and not getting out like it should be. You can either have congenital hydrocephalus or acquired from some injury or other problem, tumors and things like that, something that's blocking that system. So here's some pictures. If you want to have some nightmares, look up hydrocephalus in Google. This is one of the more mild pictures I found. There were some really big-headed babies that didn't look right. But when this happens in a baby, again, their skull is still forming. And so as those ventricles get bigger and bigger, the head compensates by growing bigger and bigger. You can have quite a big head circumference. So the ventricles are too large. They're causing pressure on the brain outside, which then pushes their head out. The treatment for this, if you can't treat the cause, is to place, one thing you can do is place a VP shunt. So this is an internalized shunt. It goes into the ventricular space and drains out. They have a catheter that's kind of implanted under the skin. It goes all the way down through the neck and into the peritoneum. So it allows for that CSF to come out of the ventricles and eventually be taken down to the peritoneum where it can be reabsorbed there. So manifestations. So it depends how rapidly the ICP increases. If this is a gradual change, then you may not see a lot of obvious signs and symptoms right away. It can be very slow progressing. The biggest thing that's, the first symptom that some kids have when it is this slower progression is that increased head circumference. So, we kind of, you note on their normal well visits, oh, this FOC is, getting in the higher percentiles. Let's look into that. But you can have some of these other symptoms as well as it gets worse and the pressure gets higher. So poor feeding, sunsetting eyes, that's this picture down here, kind of where the eyes want to stay down all the time, and that's because of the pressure on the eye itself. A cracked pot sound, so that's if you did percussion on their head. Nausea, vomiting, headache, unsteady gait, changes in their school performance if they're old enough, and behavioral changes. So if it's acute, you can have cerebral hypertension and a rapid deterioration. And for this, you want to, figure out what the cause is. You might need a surgical placement of a shunt. Could be, if it is an acute condition caused by something that's fixable, then you might just need an EVD that can be then taken out. But again, they might need a VP shunt. Okay, moving on to stroke. So there's two different types of stroke: ischemic, so that's from some kind of clot causing a lack of blood flow, or hemorrhagic from a bleed. This overall, is a lot less common in kids than it is in adults, but the incidence seems to be going up, and it's becoming a more leading cause of death in peds. And that's just because, we're starting to fix some of the other things that are causing pediatric death. So as those are less and less lethal, this becomes a higher cause of death. Morbidity, so, illness and deficits following a stroke is higher than 50%. That's pretty high with neurologic or other deficits. And again, you can get this from an embolus, thrombus, or some kind of occlusion that's blocking that blood flow. So risk factors, there can be a lot of different things from different disorders. Anything that makes you more likely to bleed or to clot is going to put you at risk for one or the other. So some diagnostic studies for stroke. So you're going to check all their labs. Obviously, you're also going to want to do a urine tox screen. This is just to rule out any ingestion or overdose of something that might be causing the symptoms, that have the same kind of symptoms as stroke. You're going to want to do radiologic studies, so non-contrast CT. This is going to help you differentiate between whether it's ischemic or hemorrhagic. CT angiography, where they inject dye in, and this can help pinpoint exactly where the problem is so that they can possibly fix it. And then maybe an MRI and an echo, because you want to look in the heart to see if there's a possible source of the thrombus. Sometimes, we just had one recently. A kid had a huge clot in his right atrium ventricle area that had to be taken out. But, something like that's just, clot somewhere else in the body can easily break off and then cause stroke or problems in other areas. Okay, so treatment for a stroke. Again, maintain normal oxygenation and ventilation. You want to try to get as much oxygen to their brain, what you can perfuse to their brain as you can. Treat any systemic hypertension they may be having in response to that. Also, because especially if it's a hemorrhagic stroke, hypertension can make it worse. You want to normalize their blood glucose, control any fever. They might need thrombolysis. So chemically or pharmacologically, you can do this with TPA. And they might at least be on a heparin drip to keep the clot from getting worse. And for older kids, you can do aspirin to prevent further stroke, especially if they have conditions that put them at risk for it. So intraventricular hemorrhage. This is more talking about like what happens in infants. Especially preterm infants are at an even higher risk for this. So it can often develop in the first few days of life, even in a normal, quote unquote, normal preterm infant, but especially if they have any other problems going on. So hypernatremia is a risk factor, blood transfusions for a preterm or newborn. Shock and acidosis can really increase their chance for this as well. And signs and symptoms of this, you could see a change in their level of consciousness. They could start to look shocky, have, an onset of acidosis, new seizures, bradycardia, or apnea. And this is usually diagnosed with that head ultrasound that you can do through their fontanelle. Okay, moving on to traumatic brain injury. So this is a pretty generic term, covers a broad range of things, but it's any brain injury caused by an external force. Motor vehicle collisions are the most common cause, and if boys are twice as likely as girls to get TBIs, and this is just because of all the crazy and rambunctious things that boys can do. Girls can get into it too, but boys seem a little more prone to that. But again, your goal in this is going to be to maintain that cerebral perfusion pressure and try to keep the brain, as perfused as you can. Signs and symptoms, you're going to see an increased ICP. It's going to based on the location and the severity of the trauma. So for diagnosis, skull X-rays, CT, MRI, and you're going to treat based on symptoms. So what are some ways this can happen? First of all, from fractures, usually from some kind of linear or simple skull fracture. You can also have a concussion, and this is a blow to the head with or without shearing injury and with a positive loss of consciousness. A contusion is a bruise on the brain. It's not as common in kids as it is in adults. And then just the contra coup injury. So this is, injury to either the side of the head that was struck or injury on the opposite side because the brain bouncing off the skull. So let's talk about skull fracture, since this is one of the big causes of a TBI. So you can have linear, so that's a very simple fracture. Think of a hairline fracture. The bones are in alignment, nothing's out of place, meninges aren't torn, nothing like that. But a depressed skull fracture, this is where the skull is indented into the brain, and so there's damage to that underlying brain tissue. A compound fracture is going to be open, so you're going to have a scalp laceration along with it. It can be depressed as well, or it can just be, multiple broken pieces. But because of that scalp laceration, it can allow foreign bodies into the skull cavity, which is going to increase your risk for complications and infection. And then a basilar skull fracture is that fracture in the posterior base of the skull. So it's inside the skull itself, somewhere along the base. So here's a picture of skull fractures. As you can see, a hairline or linear fracture is a simple one, no misplaced bones, depressed skull fracture here. And a lot of these are going to be surgical. Sometimes you can wait and see, but anything more than 5 millimeters depressed into the skull below the normal level of the skull is going to need surgery. And then a compound fracture. Basilar skull fractures, they like to ask questions about these. There's a couple signs that we like to look for. So battle sign here on the right is bruising and swelling behind the ear. Then raccoon eyes is going to be periorbital bruising. So if you see either one of these, mentioned in a question, you're going to want to think basilar skull fracture. This shows a break in the temporal bone, but it can be any of the bones that make up the base of the skull. So I think the acronym TOES is what I've heard before, but temporal, occipital, E, and sphenoid. Can't remember what E is right now. But it can be any of those. They're probably not going to ask you exactly which bone it was. The important thing to remember with these is you're going to want to look, if you see these symptoms, the raccoon's eyes or battle sign, you're going to want to look for clear drainage from the nose or ears, because that could be CSF draining out. So you can test that drainage for glucose. If it has glucose, it's CSF. Sometimes they'll heal on their own. They might need surgical repair, but they're probably going to need prophylactic antibiotics to prevent infection, because if that CSF is coming out, other things can also go into that brain space and cause infection. And the other thing that's important to remember with these kids is if you suspect a basilar skull fracture, you never want to put an NG tube into them, because that could go in through, a hole or opening in their nasal passages and up into their brain. So if you need to put some kind of tube in, feeding tube or something, you're going to want to go OG. All right, diffuse axonal injury. So again, axonal, that is that long piece of nerve coming off of a neuron that's carrying the signal away. And so a diffuse axonal injury is mechanical shearing followed by deceleration. This is usually some kind of high-speed injury, and it tears those axons. So depending on how extensive that injury is how, we classify it as mild, moderate, or severe. So in a mild DAI, you're going to see a coma state for 6 to 24 hours. With moderate, you're going to see a coma state for more than 24 hours, but little or no brainstem involvement. So it's not quite that low. But severe, you are going to see that brainstem involvement. Okay, so TBIs, you can also, again, see with these secondary brain injuries. So you have that initial injury to the brain, you have that swelling, you have that injury, and if you don't control it, you can see these other secondary brain damage as well. So that can be a hematoma. And you see those a lot, especially with skull fractures. You can see a concurrent hematoma develop. Cerebral swelling from the injury. Infection, herniation. If the ICP gets too high, it's going to herniate and push that brainstem down through the base of the skull, which is then going to result in ischemia and can lead to brain death. So hematomas. There's a couple main kinds. There's you can have them anywhere in the brain, and they're defined or named by where they occur specifically. So an epidural bleed is going to be above the dura mater. This is typically an arterial bleed, though it can be venous, but most of the time it's arterial. And the way I remember that is just that epidural and arterial both start with vowels. So arterial bleed, that's going to be one that can get much worse, much faster than a venous bleed. So a lot of times these kids will have a brief loss of consciousness, some kind of head injury causing a fracture. That fracture tears an artery, and they might wake up, they walk around, and then they have a rapid deterioration as that epidural bleed gets worse much faster. And then you can see pupil dilation, ipsilateral or same side to the injury. On the other hand, a subdural bleed is usually venous, and this is where the blood accumulates below the dura, or between the dura and the arachnoid. So, and that one can be more acute, subacute, or even chronic, and usually doesn't deteriorate or progress as fast as the epidural, again, because it's venous, not arterial. So this is a kind of a picture of how those happen. You can see for an epidural bleed, this kind of shows the little skull fracture to go with it, kind of tears that artery, and you get a big, can get a rapidly collecting area of arterial blood, as opposed to, the subdural hematoma, which is this, slower collecting area of venous blood. Okay, brain death. So this is if other injuries progress to the point where it's brain death. It's an irreversible cessation of cerebral blood flow. You've caused enough damage that then that brain tissue dies. And it causes an irreversible cessation of blood flow. There is an absence of neurologic function with a known irreversible cause of coma. So you want, if you're going to declare brain death, identify the cause of the coma. The confirmation process is different from state to state, but there are some national guidelines that the American Academy of Pediatrics came out with. They created a task force on brain death in children, and they came out with some general recommendations and guidelines. So first, you want to exclude any known reversible cause. They're going to be in a coma. They're going to lose all brainstem reflexes. They'll have apnea. So if you're seeing this patient in the hospital, they're going to be intubated and on a ventilator because they are unable to breathe and have no drive to breathe on their own. They're going to have flaccid tone and absence of any spontaneous movements. Although you can, even though they lose all their brainstem reflexes, they can still have spinal reflexes, which can be a little confusing for the families, especially. I remember a brain death patient I had, you could touch their hand in a certain way and they'd always twitch it in a very certain way, but that was a little confusing for families for a while because they felt like, they were reacting to their touch. But it's just a spinal reflex, which means that signal is just going to the spine, coming back out, and never reaches the brain because the brain, unfortunately, is dead. So to declare brain death, you need 2 separate exams, and there's a period of time in between. So all of this, by the way, is for above 37 weeks gestation. Any baby who's preterm less than that cannot be considered or declared brain dead. So above 37 weeks gestation, term newborns up to 30 days old, you need at least 24 hours between the 2 exams. And then for infants, children, adults, it needs to be at least 12 hours. Okay, again, you want to find or have an irreversible cause that you can identify. There's going to be a physical exam as part of the brain death test that checks a lot of these brainstem reflexes. So you're going to check pupillary light response, and they're not going to have any pupil response. They're going to be fixed. You'll check oculovestibular reflex and doll's eyes, and we'll talk about those in the next slide. An apnea test, you can do, these last 2 aren't really necessary, but you can do it if you need to, an EEG or a cerebral blood flow study. Okay, so these are the 2 reflexes I just mentioned, oculovestibular and doll's eyes. So the top one here, top left, is a normal reactions for looking for the doll's eye response. So in a normal patient or a comatose patient who has brain activity and brainstem activity, when you passively turn their head, their eyes are going to stay fixed on a point in front of them. Even if they are blind, even if they can't really see anything, they're in a coma, and even if there's nothing present there to see, their eyes are going to stay fixed as if they are looking at something. And same with up and down, you'll kind of stay fixed on that point in front. For no brainstem activity, and this can also include if they have some kind of brainstem lesion, which is why we check other things, not just one reflex. Their eyes are going to stay in the same spot in their head, if that makes sense. So as you move their head, their eyes are going to stay in line with their head. Next down here is oculovestibular reflex. So this one, you're going to take ice cold water, so it's like a bucket of ice filled up with water, a big 60 cc syringe with a little catheter on the end, and you're going to flush that ice cold water against their tympanic membrane. You do not want to do this in an awake person or a non-comatose person because it's very irritating and can cause problems. But so if you had a comatose person, you flush 50 to 100 cc's of water against that tympanic membrane. Their eyes should deviate towards the side of stimulation. So if you're on the right ear, both eyes deviate to the right, and they could have, if they have some kind of lesion or other, damage in part of the brain, but not the whole brainstem, you might just see one eye deviate. But you're going to see deviation. That would be a normal response. If you have no response or no reflex, their eyes, like in this bottom picture, they're just going to stay fixed to the front. And then you're going to wait 5 or so minutes and do the other ear. This is the cerebral brain flow study. This one on top is actually a CT angiogram showing no brain flow. So on this side is a normal brain, and then on the right is injecting the dye, and the blood is not flowing into the brain. This is the more typical, this bottom part is the more typical way a cerebral brain flow study works, or looks, how it's going to look. But you inject dye in, you take these pictures, and you're going to see no dye, no blood with dye in it is getting into the brain because there is no perfusion to the brain. Next, you can do, or you're going to want to do an apnea test. And usually the cerebral brain flow study, EEG, those are things you might do if you need to for the family. But if you can't do an apnea test for some reason, those might be studies you do if you can't. So an apnea test, a positive test would mean you have no respiratory effort with a CO2 above 60. So what you usually do for this is you make sure all their numbers are in the box. You want their CO2 around 40. Their pH should be normal. Their temperature should be normal or at least above 36.5. You don't want to do this on a cold hypothermic patient because that could be a reason for their lack of response. So once you do that, they're going to be intubated because they're not going to be breathing. You take them off the vent. You provide some sort of passive oxygen flow. So usually a catheter placed down towards the carina that's just flowing oxygen in is enough to keep their oxygen sats normal. And you're just going to watch. You're going to monitor. You're going to watch the monitor, make sure they're not getting hypoxic, because if they desat, you have to stop the test. And you're going to do serial ABGs every minute or so. So if you're starting with a CO2 around 40, you're going to want to wait until the CO2 gets above 60 and or more than 5 minutes. So I think I've seen this go on as long as 10 or so minutes. And then once their CO2 is above 60 and they have no respiratory effort, that means they've passed or failed, or how we're going to say it. They have a positive apnea test, which is an indicator of brain death. Because remember, your drive to breathe is not from low oxygen levels, it's from high CO2 levels in a normal person. So when the CO2 level gets that high and their brain's not responding with an effort to breathe, that's how you can, that indicates brain death. Okay, moving on. Encephalopathy. So this is another generic term, but it's any neurologic disorder of unknown or non-infectious cause, even though some of these have infections listed, but it's kind of more of a reaction after these infections. So etiologies, you can get this from lead poisoning. You can get it from a hypoxic event, such as HIE, hypoxic ischemic event. You can get it from hypertension, metabolic disorders like hepatic encephalopathy with, a high ammonia level can cause that. After herpes or chickenpox infections, it's been seen after some vaccinations, and then with Ray's syndrome, which we'll talk about in a second. So signs and symptoms, again, decreased level of consciousness, irritability, you can see seizures, sensory motor defects, headache, and hyperventilation. And it's a diagnosis of exclusion. So you're going to want to rule everything else out, and then you say it's encephalopathy, but their lumbar puncture is going to be negative, and just a good history and physical exam. And then treatment is just supporting their symptoms, so decreasing their ICP, things like that. So Ray's syndrome, this is associated with aspirin use in children. That's why we say not to use aspirin in children, but it can also be seen after a viral infection. It's associated with liver dysfunction. You're going to see a toxic metabolic encephalopathy and fatty infiltrates in their liver. It just depends. It can have a range of severity, so it can be self-limiting or pretty severe, but you're going to see an increase in their liver enzymes, increase in their ammonia, a decreased glucose level, coagulation abnormalities, cerebral edema, increased ICP, and it can even lead to multi-system organ failure. All right, neurologic infectious diseases. Meningitis. So this one is unfortunately close to my heart because I have had bacterial meningitis. My cohort, Caroline, who's not here with me on this re-recording, has had viral meningitis, so we've kind of both had some of this before, but it's an acute inflammation of the meninges and the CSF. So the meninges that line the brain and the spinal cord get inflamed, infected, and cause problems. So CSF, you can kind of read through it here, but it's easier a little bit to show a grid on this page. So with bacterial meningitis, this is what you're going to see in their CSF. So you do an LP, that's how you diagnose it. For bacterial, their white blood cells are going to be increased, whereas viral, they may be normal, they may be just slightly increased, so it's not going to see as big of a jump. Protein is going to be increased with bacterial meningitis, and either normal or very slightly increased with viral. Glucose is going to be decreased with bacterial and normal with viral. Your gram stain is going to be positive for bacterial meningitis and negative for viral meningitis. Again, because viruses are too small, they don't show up on a gram stain. And then color of their CSF is going to be cloudy for bacterial, and that's because of those white blood cells causing a cloudy appearance, but for viral, it's going to be clear. So basically for viral, everything is going to look pretty much normal, and bacterial is going to be different. Increased white cells, increased protein, decreased glucose, and a positive gram stain culture. So the big thing to know about this, I saw a lot of practice questions that had to do with this, and they like to give you numbers of things and then ask you what you think it is as far as bacterial or viral, or ask you what you think you should do. So should you start antibiotics or something else? So based on knowing what it is and then what you would do for it. So unfortunately, these are just numbers you're going to have to memorize because they're not going to tell you what normal is. They're not going to tell you that it's high. They're just going to give you a number and ask you what it means. So protein in CSF is 10 to 30, glucose is 40 to 80. This white cell count I found from one reference. There's actually a practice question that we're going to have later that did not go with that at all. So I don't know if the denominators or what it's looking at was different or what, but so you might want to look that up in some reference. Sorry, I don't have that here. But anyway, protein 10 to 30, glucose 40 to 80. So memorize that. Again, lumbar puncture is a definitive diagnosis, but you can have contraindications and reasons not to do it. So if you have a reason to expect a closed head injury or other reason for increased ICP, you're not going to want to do it, because if you do a lumbar puncture when their ICP is increased, you're just going to get a gush of CSF, which changes the pressure too fast, can cause some herniation, so you don't want to do that. Their platelets need to be, a contraindication is below 50,000, so they need to be above 50,000 because it's a bleeding risk. And then afterwards, they're going to need to lie flat for at least an hour, and usually low activity for at least a day, because they can develop a spinal headache, and that's just from a very slow CSF leak at the site of that puncture. Okay, bacterial meningitis. So age-related pathogens. For newborns that get this, it's typically from E. coli. It can be from group beta strep, listeria, or enterobacter. Also, this is a bacterial page, but newborns can get it from HSV, is a common one. Above 2 months and older children can also be group beta strep, but you're probably going to see more likely some of these other things. Streptococcus pneumonia, which is what caused mine, Neisseria meningitis, and Haemophilus influenza. Okay, so what are the signs and symptoms? You're usually going to see a fever. You're going to have photophobia, so that's sensitivity to light. A headache, either in the frontal or occipital regions, or sometimes all over. Nuchal rigidity, so that's a stiff neck, neck pain, altered level of consciousness. Koenig sign, which is pain with extension of the legs, which is stretching that spine and irritating the meninges. Brudzinski sign, which is when you flex their neck, you're going to see their hip and knees flex. Sometimes you can see a nonspecific rash. You can also see, if it gets bad enough, seizures, sensorial neural deficit. I don't know why I wrote it that way. Sensorial neural deafness and focal neurosigns. But in infants, again, they're not going to be able to tell you that their neck hurts. They can't tell you that their head hurts. So you can see a lot less specific signs, and it can be harder to pick up on. So for management, bacterial meningitis, the most important thing is IV antibiotics. You want to start them as soon as you can. They're going to need to be on isolation for the first 24 hours after you start antibiotics. You may or may not need steroids. That is kind of controversial. You can do a CT MRI to rule out other issues like hydrocephalus or an empyema, and then monitor for SIADH. Since this is irritation inside the brain, you can see either one of those, sometimes going back and forth between them. And we'll talk about those more in endocrine in a little bit. All right, so seizures. Moving on. So seizures is any kind of, or the definition is any uncontrolled, time-limited alteration in behavior that results from abnormal electrical discharges from cortical neurons. So I know we've all seen a lot of seizure patients. This is one of the most common neurological disorders in kids. And a lot of times it's, a symptom of something else. but it can be idiopathic. So status epilepticus is a prolonged seizure or multiple consecutive seizures without regaining consciousness. So a partial seizure, this is just from one part of the brain, so it's just going to affect one part of the body. You can have simple partial, complex partials, or partial as a secondary result of a generalized seizure. And you can also have partial seizures that progress to a generalized seizure. A generalized seizure is coming from both hemispheres or the whole brain, and it can present in a lot of different ways. So you can have an absent seizure where they're just staring off. Myoclonic is sudden, brief, generalized muscle contractions, and this is the kind you see with febrile seizures. That's from temperatures above, definition is above 101.8, and usually in kids 6 months to 6 years. A myoclonic infantile spasm is head bobbing or body jerking, and this is for kids usually 3 to 8 months. And then you can have tonic, you can have clonic, or you can have tonic-clonic or grand mal seizures. So what's your management? So anticonvulsants. You want to make sure in the moment that you're protecting and supporting their airway and their perfusion. Assess for any aura presence and type. A lot of times parents or patient can tell you like, oh, this is what I do before a seizure, or they see some symptom and they can like, oh, they're about to have a seizure. They can identify that aura and kind of then prepare. You're going to monitor the length of the seizure. They're probably going to have some incontinence and they may have loss of consciousness. And a lot of them have there'll be a post-ictal phase for a while where they're a little, have some decreased level of consciousness, and that's normal. So medication management. Benzodiazepines, so diazepam and lorazepam are an initial treatment to, initially stop the seizure because they have a quick onset, also a quick half-life. But the side effects of this are going to be hypotension, laryngospasm, and respiratory depression. So put a big star by respiratory depression. If you give too much of this, this is the kid that comes in with status epilepticus. They give 3 rounds of Ativan in the ER and then have to intubate. Moving on from that, you can do phenytoin. I don't have Keppra on here, but you can do Keppra. And the big thing to remember, and what you might see a question about, is with benzos especially or something, if you're giving a treatment for seizures that causes a respiratory depression, you might see a question, should you then give the reversal agent for benzodiazepines, or should you prepare to intubate? And the answer is going to be usually intubating, protecting their airway. You don't want to give something to reverse the benzos or the treatment for seizures because then they're just going to seize again and you're going to be back to square one. So you want to intubate, protect their airway to get them through that period so you can get some of these other medicines on board that don't have that respiratory depression and try to control their seizures with those. Okay, spinal cord injuries and malformations. All right, spinal cord injuries. These can be complete, so the whole spinal cord is injured. It could be incomplete, just one side. So complete causes a complete lack of sensory and motor function below the site of injury, and incomplete, there's still some signals getting through. This long acronym is more common in peds, but this is some kind of spinal cord injury without a radiographic abnormality. So their MRI, CT might be normal, but they still have the spinal cord injury. The most common cause in kids is a motor vehicle accident. So treatment, the most important thing is steroids as soon as possible to minimize the amount of neurologic damage. So you want to try to decrease the swelling from the injury that occurred to preserve spinal cord function as much as possible. They might need a spinal fusion. If there's broken bones, broken vertebrae along with it, might need to fuse all that together to prevent any further impingement on the spinal cord, and they might need some traction immediately post-op. Autonomic dysreflexia. So this is a syndrome that you can get from after a spinal cord injury. So there's some kind of, this happens, what you see is a sudden onset of excessively high blood pressure. It's life-threatening because their blood pressure can just keep going up and up and up. It's seemingly for no reason, but what's happening is there's some kind of stimulation of the sympathetic nervous system. You see this with after spinal cord injuries that are at the thoracic level, so T6 or above. So what happens is there's some kind of stimulation, usually below the level of injury, that the patient can't necessarily feel or react to, except that their sympathetic nervous system still has that sensation, or it can still sense it and then reacts to it. So a lot of times this happens with their, a lot of these patients have to cath themselves. If they haven't cathed themselves in a while, they still have a full bladder, sometimes because of a bladder infection. They have full bowels. They need to have bowel movement. They're impacted or constipated. It can happen from too tight clothing, just something that stimulates that sympathetic nervous system. So their blood pressure increases, and then their autonomic nervous system responds with vasospasm. So it's just kind of a vicious cycle. The big thing on this one is to remember that you need to find and remove the source of stimulation. So empty their bladder, make sure they are, they help them have a bowel movement if they need to, if they could be impacted, so they might need disimpaction. Check for any tight clothing, check for any pressure ulcers that are developing, anything like that. And then you might have to treat the hypertension in the meantime till you can find and remove that stimulus. Okay, moving on to spinal or neurogenic shock. So we'll talk more about shock a lot in the multi-system review in the last session in a couple weeks. But the biggest thing to remember about this type of shock is it's a distributive type of shock. So the other type of distributive shock is anaphylaxis. So the biggest key characteristic of that is vasodilation. You're having that low blood pressure, that shocky picture because of vasodilation. So one of the first things you're going to see is hypotension, where, you think of other types of shock and you think, well, your body compensates for a while. You don't maybe see hypotension the first thing. With spinal shock, because of that vasodilation, hypotension is one of the first signs. So, and again, we'll talk more about shock in multi-system review. All right, let's move on to some spine abnormalities or malformations. So first off, let's just look at, this is a picture kind of comparing the three main kinds. So spina bifida kind of includes all of these, but you can have spina bifida occulta where there's no outer or sign other than possibly a tuft of hair or a dimple, but there is a malformation of the vertebrae themselves, which can impinge on the nerves and still cause problems. A meningocele is an extruding sac of just CSF, but you can see it outside the body. And then a myelomeningocele is an extruding sac that also involves the spinal cord and nerve involvement. So a myelomeningocele, this is where there's meninges, CSF, so that protruding sac is lined with the meninges. So it's a sac of meninges that either has CSF or nerves. So a myelomeningocele is the meninges, CSF, and nerves that are herniated through that defect. Symptoms are going to depend on where exactly that defect is and how big it is. It can also be associated with hydrocephalus and Chiari malformation. We'll talk about Chiari in a second, but there are things you can also see along with this. This is going to require a surgical closure within 48 hours, and you're going to monitor for hydronephrosis and neurogenic bladder. So some considerations, you're going to want to keep the infant warm. Pre-op, you need them in the prone position. You don't want them laying on that sac. They're going to have a moist, non-adhesive dressing over top of the sac, and you're going to want to keep it clean, keep urine and stool off of it. You're going to want to measure their head circumference, their OFC, because again, they can have hydrocephalus along with this. A neurogenic bladder is a common thing that you see too, and bowel incontinence. They might need orthopedic care. They might need help, braces, or things to walk later. They might have trouble ambulating later and not be able to. A lot of these kids, all forms of spina bifida have been correlated with latex allergies. So a lot of these kids will also have latex allergies. And then, again, because they might have hydrocephalus, they might have VP shunts, you're going to want to look for complications with that. All right, meningocele, so that's the herniated sac, but just meninges filled with CSF. There's no spinal cord involvement. They can be asymptomatic. They could have a normal neuro exam, but because that sac is extruding, it can allow for leakage of CSF, and so you're going to still want to fix it to prevent, any meningitis, risk for infection, things like that. Spina bifida, so this is a result, it's the failure of that neural tube to close very early on in development. So weeks 3 to 6 of embryologic development. It can be caused by a lot of things, from radiation, maternal diabetes, vitamin deficiencies, especially folic acid, and you can have, genetic factors as well. So the degree of neurologic impairment is dependent on the level of lesion. So it depends where on the spine that is, depends on how bad their impairment is. So usually it's in the lumbar sacral area. So if it's from L5 to S1, pretty low down, then ambulation is possible. L3 to L4, a little higher up, ambulation is possible, but might need some assistance. And then L2 to L1 is going to cause paraplegia. So signs and symptoms: tuft of abnormal hair, a dimple, or a hemangioma, all of those right on that lower part of the spine. All right, a Chiari. You might hear this called Chiari, maybe Arnold Chiari, but this is a malformation inside the brain where the cerebellum is right here. The tonsils, which are the bottom part of the cerebellum, slip into this space where the spinal cord travels. So you've got that hole at the base of the skull where the spinal cord goes through, and this bottom part of the cerebellum slips down into that space. So it looks more like this on the right. In essence, it's a herniation of the cerebellum into that space. And so this can cause obstruction of the CSF and other problems. And it can be, relatively mild. Sometimes these kids do fine without any problems, but it just depends on the level of herniation, how bad it's going to be. All right, moving on to space-occupying lesions, which is a fancy term for brain tumors. So brain tumors are actually the most common form of cancer in children ages 5 to 10, and they're classified depending on their location, their degree of malignancy, and other features. So one way to classify them is by their location. So supratentorial is going to be above, in either hemisphere of the brain, above the tentorium cerebelli, and then infratentorial is going to be in the brainstem. Management, again, it depends on the size, depends on the location. A lot of times they have surgery to remove them. That's a lot of the cranies that we see. And so then you're just going to look for and manage post-op complications. And then sometimes they may or may not need either radiation or chemo. All right, AVMs, arteriovenous malformations. So this is, you can kind of see the picture on the right. It's a tangled mess of vessels where there normally should be a nice little, capillary bed allowing good blood flow and perfusion through an area. Instead of that, you get these, there's no capillaries. It's just kind of a mess of vessels that are directly between the arterioles and the venous network. The problem with this is that blood can flow way too quickly through this area, and you're not going to have as good perfusion. AVMs are usually present from birth. They just don't usually show up until at least age 10 or so. So for these, hopefully you can catch them before they rupture. A lot of these are prone to rupture as they get older and sometimes very suddenly. But if you catch it before, you're going to want to monitor their ICP. You can do laser therapy or embolization and surgery for total excision. Issues with things like ICP and stuff, that's usually going to be from the ruptured ones. Okay, Guillain-Barré. There's a couple different autoimmune neurologic diseases, Guillain-Barré and myasthenia gravis. So we'll talk about those briefly just to compare the two. So again, they're both autoimmune diseases. Guillain-Barré is an acute inflammatory demyelinating disorder. So demyelination, that myelin sheath of those axons, it's because of inflammation gradually removing that myelination. The hallmark of this is ascending symmetrical paralysis. So usually starts on the legs, goes up to the arms, trunk, and then to the face, and it can affect their respiratory system. There's usually some kind of history of previous infection, a few weeks before this shows up. And again, this is autoimmune, so it's an overreaction of their immune system to that previous infection. So they're going to have progressive motor weakness, again, ascending. So the biggest thing to remember with this is once you start, if you see that the effects go further and further up, you're going to start to really worry about their airway and their breathing. you're going to see an elevated CSF protein count, but a normal culture. And then management is just supportive. Support their symptoms. You can do, since it's autoimmune, you can do plasmapheresis and or IVIG. Myasthenia gravis is also autoimmune, but it's of the peripheral nerve. So and this involves the acetylcholine and cholinergic nerve conduction. So antibodies are causing a blockage that lead to impaired cholinergic nerve conduction. So what that results in is progressive muscle weakness. It's not that ascending weakness and paralysis you see with Guillain-Barré, though. A lot of times, the thing I think about these is the ptosis and diplopia. The weakness especially affects their optic muscles. So these are the ones that walk around with their eyelids half closed because they can't open them. And then management is, again, supportive care. Because it's involving the acetylcholine receptor sites, you can give them cholinesterase inhibitors. You can increase the amount of acetylcholine, which then increases the amount of acetylcholine available. You can give neostigmine, pyridostigmine, corticosteroids, and IVIG, and that's for the immunosuppression part. All right, moving on to musculoskeletal. First off, compartment syndrome. So this happens after some kind of injury to a limb, usually. You can have abdominal compartment syndrome, but this is musculoskeletal, so we're talking about in a limb, an arm or leg. So the muscles themselves are made up of a lot of different compartments. And those compartments when the pressure gets too high in those compartments, it can impair the perfusion, and it can result in tissue damage or death. So it happens when the pressure in that compartment exceeds the capillary perfusion pressure. So capillary perfusion pressure is the amount of pressure that the capillaries need to push the blood through. So when the pressure in that compartment gets too high, it's squeezing that blood, not letting that blood get in. So there's decreased blood flow to that muscle tissue. The hallmark of this is the 5 Ps. So you're going to want to look for pain. They're going to be excruciating pain, pallor, pulselessness, paresthesia, so lack of sensation, and paralysis, lack of movement. Treating this is going to be to elevate the extremity, but they're most likely going to need some kind of fasciotomy. So you're going to be calling the doctor, get them in there for a fasciotomy to cut into that myofascial compartment to relieve the pressure. And then along with that, you're going to monitor for rhabdomyolysis, and we'll talk about what that is in a second, but that's a result of the tissue death. So, rhabdomyolysis. This is a disintegration of muscle tissue. The muscle tissue itself has been damaged and has died and is now breaking apart, causing problems. So it's associated with crush injuries, with electrical shocks, severe burns, extended immobility, and again, it can be due to reperfusion to damaged cells, such as in compartment syndrome. So what you would want to look for with this, usually you'll see their electrolytes are going to be abnormal because these damaged cells are breaking apart, releasing potassium and other things. You're going to want to look for, usually the big sign of this is tea-colored urine. So it's kind of in between, it's more than just concentrated, like it has some of that brownish color, and that's from the myoglobin. So the myoglobin, as it's being released from these damaged muscle tissues, goes into the blood. And once it gets to the kidneys, it starts clogging up those renal tubules. So you can see acute kidney injury from this and renal damage. So you're going to want to make sure these kids are well, have lots of IV fluid. They may need boluses. You want to flush those, give those renal tubules as much fluid as possible to kind of flush them out and prevent any, long-lasting kidney damage. All right, delirium. This is a hot button issue for us right now, and again, it is for the CCRN. So this actually was not in the CCRN test plan for 2015. This is one of the things that has been added for 2020, so you're probably guaranteed to see at least 2-3 questions on delirium. So this is under-recognized in children, and it's any change in their baseline mental status. So you can see inattention, you can see disorganized thinking, some kind of altered level of consciousness. The thing to remember with this is there's different kinds. So you think of like confused delirium, but you can also have a hyperactive delirium, a hypoactive delirium where they're really not doing very much. So you're going to look for any alteration or change in their mental status. So risk factors is illness severity. So this is, we're thinking of what we see. This is as a result of some kind of prolonged illness, prolonged hospitalization, and how bad their illness was kind of will affect how bad their delirium can get and the kind of medicines and interventions that we have to do for their illness. It's usually the result of an interruption or alteration of their circadian rhythm. So when we're interrupting their sleep cycle, we're bothering them all the time, trying to save their lives or do our assessments or different things like that. But interrupting that normal circadian rhythm, interrupting their sleep more than we need to, really puts them at a higher risk for delirium. So screening tools for this, you're going to want to use ones that are developmentally appropriate. But in going through the practice questions for this, the ones I saw a couple of different ones, 2-3 different ones that talked about the RAS score, which is something they use more in adults. But I saw them in our pediatric questions, so I'm going to show you what this is here. But you might want to look this up for yourself and just make sure you're familiar with it. So it's the Richmond Agitation and Sedation Scale. And basically, to me, if you think of our SBS scale, it's kind of that expanded. So whereas our SBS goes from like -3 to +2, this goes from -5 to +4. So but same kind of thing. Just think the higher the number, the more positive, the more agitated and combative they are, and the lower it is, the more sedated they are. So ones in the +2, +3, +4 range are going to need some kind of intervention for that. All right, suicide. This is unfortunately too common, and especially our adolescent patients, and it's starting to see younger and younger. But it's just, many adolescents feel despair. Suicide itself can be romanticized, especially by shows like 13 Reasons Why, or stuff like that. It's just it becomes this idealized, romanticized notion. You can see increased depression, and there's several risk factors. So the biggest, most significant risk factor is some kind of psychiatric diagnosis. So a diagnosis of depression, of conduct disorders, bipolar disorder, anything like that. And then also these other things are risk factors as well: substance abuse, domestic conflict, history of prior attempts of suicide, family history, and antisocial behavior. So for this, you're going to want to make sure, we do this now, and we've had luckily some education recently about suicide, but you want to make sure you're screening for this and asking them the questions. If they are an adolescent, and if you can, get the parents to step out of the room, that usually helps you get more honest answers. But you're going to want to screen for previous suicide attempts, previous thoughts of self-harm. All right, moving on to endocrine. All right, so the CCRN test plan for endocrine, I don't have a specific percentage here of the test because, again, they kind of clump endocrine, GI, renal, heme, and skin all together and say that whole thing is 20% of the test. Hematology and skin are a very small percentage of that. So, endocrine, renal, and GI make up a bigger chunk of that 20%. But this is the test plan for endocrine. These are the things that it covers, and we'll try to hit as much of this, the important parts of this as we can. So in general, the endocrine system, these are the functions of the endocrine system. So it's important for regulation of 1, water and electrolyte balance. Number 2, energy production and utilization by the cell. So think glucose and use of glucose or energy. Metabolic rate, growth and sexual maturation, and circulatory function. So where you run into problems with the endocrine system can come from there's a few different ways that you can have problems. 1, there's an overproduction of a hormone, so you're making too much of it. 2 is an underproduction of a hormone, you're making not enough of it. Or you have enough of the hormone, not too much, not too little, just the right amount, but you have non-functioning receptors. So that hormone is released by a certain part of the body, it goes and talks to another part of the body through receptors. And so if those receptors aren't functioning, that part can't hear what the hormones are trying to say. And so you can have problems for that. Okay, so the first big function is water and electrolyte balance. The 4 main hormones involved in this are antidiuretic hormone, natriuretic hormone like BNP, mineralocorticoids, and then adrenal hormones. So the first three really have to do with and help with water retention. They're what's helping keep water in your body. Adrenal hormones help with water loss, getting rid of water if you have too much through your kidney renal system. So first of all, antidiuretic hormone. This, we also call it ADH. You can also call it vasopressin. That's more of the term for the synthetic ADH hormone. I like this one because it tells you in the name exactly what it is. It's antidiuretic hormone. It's preventing diuresis. Antidiuresis, anti-peeing. So it's holding water in. And this is something that your body secretes naturally in order to help regulate your fluid balance. So it increases your renal collecting ducts' permeability to water. It makes them easier for the water to come back in and stay inside your body. Your body is going to release this anytime it senses a change in your plasma osmolality, so the concentration of your blood, your extracellular fluid volume, and any changes in your blood pressure. So your blood pressure starts to drop a little bit. You think, oh, I need to secrete some ADH and hold on to some water. Or, my blood pressure is too high. Maybe I need to stop secreting ADH so I can get rid of some of that extra fluid. In addition to those effects on inside the renal collecting ductules, that's, the kidney system itself, it's also going to have a vasoconstrictor effect on blood vessels. So briefly, let's talk about osmolality. So when you see the word osmolality, think concentration of the blood. You can also check urine osmolality, concentration of the urine. There's a formula for this, for blood. So it's your sodium level times 2 plus your glucose level divided by 18 plus your BUN divided by 2.8. So a quick and dirty way to think about this, in a patient with normal glucose, because if you think of a normal glucose is 90 divided by 18 is going to be 5. That's not a big change. And BUN, same. This is not going to add much. So in a patient with a normal glucose, a quick way to think about this is your sodium level times 2. So if a sodium normal range is 135 to 145, let's just take the middle, 140. 140 times 2 is 280, and that's going to be a normal blood osmolality range. For urine's a little bit more concentrated, so it's going to be 300. And in general, because this is concentration, fluid flows from areas of low concentration to high concentration. So if your blood osmolality is high, it's going to draw fluid in. If it's low, it's going to let fluid out. All right, so let's talk about SIADH and DI. SIADH, syndrome of inappropriate antidiuretic hormone. This almost tells you what it is, though inappropriate is a little bit vague. So it would be nice if they just called it syndrome of too much antidiuretic hormone. But basically, this is an overproduction of ADH. There's too much of it. So your body continues to secrete ADH despite low serum osmolality, hyponatremia, or euvolemia. So even though all those normal triggers in the body that say, hey, we don't need ADH anymore, your body still produces it. And this can be because of a traumatic brain injury, some kind of hypoxic brain injury, some kind of injury to that part of the brain that secretes this hormone. So pathophysiology, you have that increased ADH secretion, so your brain puts too much of it out. It causes more water to be retained in the kidneys, which just increases the total volume of your blood in your intravascular space, and that dilutes out the blood. So if you're holding on to extra water is in your blood, it's going to dilute out your blood, which decreases your concentration, decreases your osmolality. It also dilutes out your electrolytes. It's going to cause a decrease in your serum sodium as well. From this, you're going to see weight gain because they're holding on to water. Decrease urine output because, again, they're holding on to water. And that urine output that you do have is going to be very concentrated. You're going to see mental status changes, usually because of the hyponatremia. It can cause headaches, seizure, nausea, vomiting as well. So diagnostic studies on this. So your sodium is going to be less than 130. It's going to be low. Your osmolality is going to be low, so less than 280. Your BUN is going to be low, again, because everything's getting diluted out. And then your urine, on the other hand, is going to be concentrated. So your urine osmolality is over 600, which is twice as much as the normal of 300. And your specific gravity is going to be above 1.03. So management, you're going to want to restrict their fluids. This is a kid who's going to be on low to no PO intake. You're not going to let them drink very much at all. You're going to give them hypertonic saline probably. And along with restricting fluids, it's going to be restricting their IV fluids as well. These are kids you're going to see maybe on third maintenance, quarter maintenance, very low fluid intake. You can give them loop diuretics to try to stimulate that, urine output and getting rid of that water. And then you're going to want to, make sure you monitor other things. You're going to be monitoring their labs, their sodium levels, especially low sodium is much more dangerous than high sodium is. Monitoring their hemodynamics, their urine output, specific gravity, eyes and nose, and their weights. Diabetes insipidus. So this is the flip side of SIADH, and it's a little easier to treat. I mean, if you have too much ADH in your blood, you can't really get rid of it, but if you don't have enough, you can give them some. So this is an underproduction or some kind of deficit of ADH. Sometimes it's not the underproduction, but it's that those receptors aren't working. It's the inability to concentrate urine. So instead of holding on to water, their kidneys are just dumping tons and tons of water in their urine, which is going to make it very diluted. And because you're dumping so much water, your blood is going to get too concentrated. So you can also get this, again, from a TBI, some kind of brain tumor, neurologic procedures that happen around that pituitary hypothalamic region. Anything that's causing damage or swelling can cause DI. So pathophysiology, it can come from one of two problems, either neurogenic from the brain, that ADH isn't being produced for some reason, either not synthesized in the first place or not secreted, or some combination, and that's from damage in the brain. You can also see nephrogenic DI, and that's, there's a normal amount of ADH in their body, but it's for some reason not getting, the renal system itself is resistant to its effects, so it's not listening to the ADH. So with this, you're going to see altered mental status as well, seizures, coma. Again, your blood's too concentrated, your sodium level's too high. You're still going to see, you're going to see problems from that. Thirst, they're going to be very thirsty. They're going to have very high urine output. Their urine's going to be so diluted, sometimes it just looks like water. And then along with that, they're dumping all the water out of their body. They're going to be hypovolemic, and they're going to be dehydrated. And if it's untreated and progresses, they can go into hypovolemic shock. So diagnostic studies, again, it's the flip side of SIADH. So their osmolality, their concentration is going to be very high in their blood. They've lost all their water, concentration's high, osmolality's high. Their sodium is going to be more concentrated too, so higher sodium. You can do imaging studies just to check for areas of damage in the brain. And then again, their urine osmolality is low, urine sodium is low, specific gravity is low because their urine is very diluted. DI, diluted urine. I don't know if that helps because not diluted blood. So however you want to remember it. Management. So you're going to want to replace their fluid deficits. They're going to be on a lot of IV fluids. Replace those ongoing losses. But then again, because this is a lack of ADH, you can give them more through synthetic ADH. And we'll talk about that next slide. And then again, monitor all their labs, eyes and nose, weights. So synthetic vasopressin. I'm sure a lot of you have seen vasopressin drips. It helps with blood pressure because, again, it causes that water retention, which helps increase their intravascular volume. It also has that vasoconstrictor effect that we talked about. But in a kid with DI, you want to give it to prevent, to manage their DI. A lot of our brain dead kids are on this because as their brain dies, it affects their production of ADH as well, and they can go into DI. So a lot of our kids who are brain dead, who are waiting to donate organs, are usually on a vasopressin drip. And that's a continuous infusion, but it can be given IM or sub-Q. And then our chronic kids with DI, you'll see them on DDAVP. So this can be oral, intranasal, IV, sub-Q. And you usually see this where you're waiting to give their evening dose till they have their breakthrough urine output. So all of a sudden they dump a lot of urine, you give the DDAVP, urine dries up. So some things to think about as you're treating this is if they're dumping tons and tons of fluid because they're in DI, and you give them vasopressin or DDAVP, that urine output should go down dramatically, which means they're going to hold volume in, which means you're not going to have to give them as much. All right, moving on, next function of the endocrine system is energy production, or glucose homeostasis. So the 5 main hormones involved in this function are going to be insulin and glucagon. So insulin is, it's the hormone you produce in response to a high glucose, helps you utilize that glucose to get into your cells to be used for cellular metabolism. Then glucagon is what your body produces in response to a low glucose to make you release more into your blood. And then these other three, will affect your glucose levels as well. Epinephrine, cortisol, growth hormone, all those will cause an increase in your glucose level. Okay, so first, insulin. This is an anabolic hormone. It's secreted by those beta islet cells in the pancreas, and again, in response to an increased serum level. So it takes glucose and helps it get into the cells, and it's also going to stimulate glyconeogenesis, so the formulation of that glycogen to store excess glucose. It also stimulates protein synthesis and formation of adipose tissue. So glucagon is the counter-regulatory hormone to insulin. It's secreted also by the pancreas in response to decreased serum glucose. So it's going to stimulate glycogenolysis, so a breakdown of glycogen, and gluconeogenesis, so glucose production. So your body senses that you have low glucose levels. It sends out glucagon to say, hey, break down glycogen, make more glucose, send it into the blood. Growth hormone, this is secreted by the anterior pituitary gland, and it stimulates protein synthesis, gluconeogenesis, and lipolysis. So it's usually triggered by some kind of stress response that says, hey, we need energy, send us all these things, protein, glucose, and lipose. So a problem you can have with this is first hypoglycemia. So this is when you have too much insulin for some reason, or a deficiency of glucagon, and it leads to hypoglycemia. So we see this a lot in our sick neonates and young infants because they're just not great at regulating their insulin and glucose or glucagon. And in general, they're littler. They have inadequate glycogen stores, so they don't have the compensatory response that we do to release, send out that glycogen, break it down into glucose. They just don't have those stores built up yet, so they're much more sensitive to the effects of insulin. So it can also be caused by some of these other things: genetic disorders, liver failure, adrenal insufficiency. That's a big one. So clinical manifestations, it's a glucose less than 60. You're going to see a decreased level of consciousness. They're going to have seizures, tremors, hypotonia. It can cause apnea, tachycardia, diaphoresis, and anxiety. So if they don't have IV access, you're going to give them some kind of oral carbohydrate, and you're going to want a simple carbohydrate like something that's straight up sugar or juice, something like that. Obviously not for babies, but older kids that have diabetes and have some problems where they have a backup for low blood sugar. You're not going to want something like Snickers that has a lot of fat and stuff in it. You want something that just is pure carbs. You can also give them glucagon as well. If they have IV access, you're going to want to give them a dextrose bolus. So if it's D10, it's 5 to 20 mLs per kilo, and D25, it's 2 to 4. You can see D50 in adults, but a lot of times for pediatric population, we're going to use D10 or D25. Okay, next problem is diabetic ketoacidosis. This is something we see a lot of. And this is, a patient who has type 1 diabetes, so they have an underproduction of insulin. They have a buildup of glucose higher and higher in their body. They can't use it because they don't have the insulin, so the glucose can't enter the cells. So the cells have to revert to something else to use as energy. And so they're going to go to their backups or protein metabolism or fat metabolism. The problem with those is the longer that happens, they have more destructive byproducts. So things that are going to raise the acid levels in the blood, ketones in the blood. So those overall, it's a lack of a cellular energy deficit because those things are less efficient as well. And then a buildup of those byproducts like ketones that are going to cause other problems. So there's three main components. First of all is hyperglycemia, so above 180 for their glucose, and oftentimes we see it way, way higher than that. Ketonuria, so ketones in their urine and their blood, but so much that it's dumping out into their urine. And then acidosis, so this is a pH of at least less than 7.3, and again, I've seen it much lower than that as well. And a bicarb that's less than 15 because they're trying to compensate for that pH by lowering their bicarb. So again, clinical manifestations, you're going to see that hyperglycemia, a ketoacidosis, so that ketones are causing acidosis in the blood. And because of the acidosis and the other things that are happening, you're going to see electrolyte abnormalities. So hyperkalemia, hyperphosphatemia, hypernatremia. Their blood is going to be, you're going to have a hyperosmolarity of their blood with osmotic diuresis. So their blood, because of that glucose level and the increased sodium level, it's going to be very highly concentrated, which is going to cause osmotic diuresis. So they're pulling the blood, that hyper concentrated blood or the hyperosmolarity of the glucose and sodium are going to pull fluid in from their body and dump it out in their urine. And that dehydration is going to can lead to a hypovolemic shock. So they're going to present very dehydrated. They can have an altered mental status and start to have increased signs of ICP. So we're going to watch out for that. They're going to have tachycardia, again, because of the dehydration, hypovolemic shock. They could have hypotension, but that's a very late sign. Their peripheral perfusion is going to be poor because of the dehydration and because of the acidosis. They're going to be tachypnic. Usually that Kussmaul respirations is what you see where it's very deep, very fast. They're trying to blow off CO2, again, to compensate for the acidosis that they're getting from the other problems. You're going to smell acetone breath. Sometimes it's called fruity breath, but it's a much more stringent smell than that. Abdominal tenderness, and then signs of concurrent infection. Because a lot of times this either happens usually because it's the first presentation of diabetes. They didn't know they had it before. It can be a kid who's diabetic who has some kind of cold or something, and it just their body can't handle it and sends them into DKA. And then you can see it because of noncompliance as well. So you get that teenager who doesn't want to be sick anymore, or sick. They don't want to have diabetes anymore. They don't want to take their insulin. Leads to DKA. So management, as with everything, your first thing is going to be ABCs. Especially as this progresses more, you're going to want to make sure their airway and breathing are okay, and then their circulation. So they're going to need fluid replacements. Again, they're very hypovolemic. They're very dehydrated. They're going to need some volume resuscitation, but ideally slow volume resuscitation. You don't want to go too fast because you don't want to cause too much rapid shifts in all of those blood concentrations. And then we want to decrease their blood sugar. We need to get that blood sugar down, but we want to get it down in a controlled, slow manner. And as you get their blood sugar down with insulin, it's going to help their body then utilize the insulin to get them out of the ketosis that's causing the problems. As that happens, their electrolyte imbalances, you're going to want to correct those and then do either family and or patient teaching about managing diabetes, whether this is a new diagnosis or a poorly controlled ongoing diagnosis. Okay, so first for volume resuscitation, you're going to get vascular access, obviously. You might start with a bolus of normal saline, and if it just depends on how bad it is. If they are in a hypovolemic shock, you're going to probably want 20 per kilo, but if they don't have circulatory collapse or circulatory failure, you can start a little bit slower, so 10 to 20 per kilo over 1 to 2 hours. Again, these kids, everything's out of whack, but you want to correct it in a controlled, slow way. So it talks about calculating the volume deficit, but I don't think you're going to be asked about that. Insulin administration. So along with fluids, they need insulin. They need insulin to start getting that blood sugar down. You're going to start anywhere from 0.05 to 0.1 per kilo. Typically we see 0.1, but for very big kids, you might see 0.05. We do not in peds usually do an IV bolus. That's used in adults a lot more, but kids are more sensitive. We don't typically do that. Their glucose. So you want to lower the blood glucose level. That's the point of the insulin drip, but you don't want to go too fast. So once you don't want to drop more than 80 to 100 per kilo per hour. So you don't want to see a drop of more than 100 per hour in their glucose. So if you see a drop of more than 100 per hour, or once their glucose gets below 300, you're going to start adding dextrose in. This says add 5% dextrose when it's less than 300 and 10% for less than 200. But typically for our kids, what you'll see, we have what we call the 3-bag system. So a bag of insulin, a bag of some kind of non-dextrose containing fluid that usually has electrolytes, potassium, phosphate in it, and a bag of dextrose fluids. And, usually you'll start with the non-dextrose and insulin, and then as their sugar drops, you slowly add in dextrose fluid and slowly decrease the non-dextrose fluid. So again, potassium, phosphate, those are the big electrolytes you're going to want to manage. And usually you don't give one-time replacements, but you're going to add them to the bag. When they first come in, you're going to see hyperkalemia, and that's just because of the acidosis drawing that potassium out of the cells. But as you start to correct their hyperglycemia, the insulin is going to carry glucose into the cells, which is also going to carry potassium along with it. So their overall body potassium is going to be too low. So you're going to want to add K and phos to the fluids. And if their hyperkalemia is bad enough when they first present, you might need to treat it primarily, but hopefully not. Usually, once you start giving the insulin and fluid boluses, you'll see the opposite problem, not hyper. Okay, so this is the big complication and the big danger of DKA. So cerebral, this says central. It should say cerebral edema and DKA. It's considered to be a complication of treatment. So cerebral edema shouldn't happen or doesn't normally happen by itself, but as we're treating them, if it's not treated and managed properly in the right way, again, with that controlled, steady decline of their glucose and other abnormalities, that's when you can see cerebral edema. The incidence overall is just 0.7 to 1% of DKA patients, but again, we're seeing in the PICU the sicker DKA patients, so our patients are at an even higher risk than that. It usually occurs in the first 24 hours of treatment, usually because that very initial part of treatment is too aggressive, and we start to correct their glucose too fast. Underlying mechanism, like as far as the underlying pathophysiology, is not exactly clear, but the mortality rate of this is pretty high. 20 to 30% of kids with DKA that develop some cerebral edema are going to die. And the majority of deaths from DKA are because of cerebral edema. So it's very, very serious, and that's the biggest thing we're trying to prevent as we treat them, because again, it's a complication of our treatment. Risk factors include a younger age. The younger they are when they present, the higher their risk. Longer duration of symptoms, so the longer this has been going on, the higher their risk. Having an increased serum sodium as well, because glucose is making the blood very concentrated, and changing the concentration of the blood, which causes the fluid shifts. But having an increased sodium as well is another big factor on that concentration of the blood. So if they have a higher sodium level during therapy, that's going to make them at higher risk. A pH of less than 7.0 initially, and having to use bicarb. So we try to avoid the use of bicarb to correct their acidosis, because as we work on other things, the acidosis will correct. But if they have to use bicarb for some reason to treat a severe acidosis, it's associated with higher risk for cerebral edema. Initial serum glucose of more than 800, and again, rapid correction of the glucose. You do not want to go faster than 80 to 100 per hour. So treatment. The biggest thing is immediate recognition and intervention, reducing their IV fluid rate. So because, this is edema, this is swelling, we're going to decrease the rate at which we're giving them IV fluids. You may use mannitol, but more likely you're going to use hypertonic saline to try to draw that fluid off the brain. And then they may need intubation and mechanical ventilation. All right, moving on to stress, hyperglycemia, and ICU. So we have plenty of kids that we see that are very sick with some other critical illness that then have a hyperglycemia. And they don't have diabetes necessarily. It's just the body's reaction to a critical illness. Sometimes they have stress hyperglycemia. There's a lot of things that happen your body's normal stress response to an illness, you're releasing all those other things, epinephrine, cortisol, all that stuff is going to increase your glucose as well. And if you're very sick, you may not, be able to utilize it as you should. So often this is a glucose above 150 or 200. And it is increased with, associated with increased mortality, increased length of stay, and increased nosocomial infection. So we want to try to prevent it if we can. They're still doing studies on the benefits and risks of tight glucose control, but these are the kids that you'll see who have some critical illness, sepsis or something. They have a glucose above 200, and we'll start them on an insulin drip to try to keep them in a tighter box. All right, adrenal insufficiency. So this is also called Addison's disease. And this is increased insufficient glucocorticoid and mineralocorticoid release or production. So the adrenal glands sit on top of the kidneys. Their main job is to produce glucocorticoids and mineralocorticoids. That's the main ones are aldosterone and cortisol. This is an autosomal recessive. It's usually congenital. And so autosomal recessive, remember, is both parents have a recessive gene and the baby gets both those recessive genes. But it can be an autoimmune process, but typically you think of it as a genetic problem. So because you don't have enough of that aldosterone cortisol, you don't have a good stress response. It's usually what you have some in your body all the time, but any stress response, your body releases that so you can deal with that stress. But with this, they don't have that. They can go into shock. They can have hyponatremia, hyperkalemia, weight loss, hyperpigmentation is a big one. So if you see anything about a kid with, hyperpigmentation on their face or something, it's probably Addison's. And then they can go into an adrenal crisis, especially in those times where their body should have a stress response, from illness, surgery. They can have hypotension and just look very shocky. All right, last one is inborn errors of metabolism. So this one, I won't go too much into this. I'm sending out these slides, or I've sent out these slides to you guys already, so you can read about some of these. I don't know how many they're actually going to ask specifically about, but the biggest thing is think genetic metabolic disorders, genetic disorders. There's some kind of blockage in the metabolic pathway. So, normal metabolic pathway in your gut is the breakdown of fats, carbs, proteins in your gut and then in your blood. These genetic diseases, there's some problem somewhere in the breakdown of those things. Usually there's a lack of some enzyme, but it results in a toxic accumulation of some substance that your body can't break down that it should. Depending on what the substance is and how bad it is, it can result in permanent damage, especially brain damage, death if left untreated. So the biggest things with these to remember is that, you're going to see developmental delay, failure to thrive, irritability. You can do newborn screenings are going to check for these, but they don't check for all of them. But the biggest thing with this is diet modification. So in general, if they can't break down lactose, you're going to want to avoid lactose. So you want a lactose-free diet. They won't be able to breastfeed. If they can't break down protein, you might need to give them a low-protein diet. There's some of these that are lacking a specific amino acid, specific enzyme that you can give to them as a supplement. An example of that is arginine. So biggest thing with these to remember is, modify their diet and manage your symptoms and watch out for, the symptoms of toxic buildup. So let's switch over now to some practice questions. So since this isn't live and I'm re-recording it, I'm going to go a little bit quicker through the practice questions. So I'll kind of read each one, and then if you want, you can pause to kind of think about it, and then I'm going to go pretty immediately on into the answer and the explanation just to save time. Okay, first of all, which of the following cardiovascular complications is an expected finding during the initial stage of spinal shock following a spinal cord injury? So A, tachycardia, B, hypotension, C, hypertension, or D, hyperthermia. You can pause it if you want to think. And the answer is hypotension. Again, spinal shock is a form of distributive shock. So the main thing is vasodilation. You lose that peripheral vascular tone, which then, causes a relative hypovolemia. You've made the system a lot bigger, and the fluid that was filling up a small system now only fills up half of a big system, kind of thing. Anyway, so the first thing you'll see is hypotension, which is usually unresponsive to fluid, to volume. It's not because you need to tighten those vessels back up. So anyway, hypotension, because it's a distributive shock. Next, an infant is admitted 2 days ago after being in an MVC with a left femur fracture. Initial assessment reveals a unilateral hip spica-cast. The nurse notes the following on the infant's left lower extremity: 3+ pitting edema, pallor, pulselessness, paresthesia, and some paralysis. Data is BP 104/56, heart rate 190, respiratory rate 58, temperature 99, which is 37.2, and oxygen 90%. The best action would be to call the provider immediately with the findings, call the provider immediately for a new pain medication, D, ice and elevate the extremity, or E, conduct a bedside Doppler ultrasound. I'll give you a second. Okay. The answer is you want to call the provider immediately with the findings. So with this is signs of compartment syndrome. So it's mentioning those 5 Ps that we talked about. You have no pulse now, some paresthesia and paralysis. Those are very emergent findings. This patient probably needs a fasciotomy, urgent surgical intervention right away, most likely. It could be a problem with the spica cast being too tight, so they might need to, assess that first, and then go on. So a bedside Doppler ultrasound, you might, after you call the doctor, after you call the provider, grab the Doppler to check that, but the provider needs to know right away because this needs immediate intervention. You can elevate the extremity is an intervention for compartment syndrome, but not ice, and it's not the first thing you'll do for this. All right, a patient is admitted with a blunt head injury. Assessment reveals eyes opening only to pain, groaning, and the patient has abnormal flexion of the extremities to painful stimuli. So those are all GCS related things. And we didn't talk specifically about GCS, but hopefully we do it enough with our assessments that you can kind of think in your head, what's this patient's GCS? The nurse should anticipate which of the following immediate interventions: intubation and a 12-lead EKG, placement of 2 large bore IVs and mannitol, rapid intubation and possible intracranial pressure monitor placement, or electroencephalogram and chest x-ray. All right, answer to this is rapid intubation and possible ICP monitor. So if you're thinking that they probably have increased ICP and need mannitol, that's probably right. But again, going back to the assessments, you have the GCS is less than 8, and anytime it's less than 8, the standard of care is to secure an airway. So you're going to want to intubate first, protect their airway, and then, look at their ICP monitor. The others are correct, but not the first thing you'll do. An infant has been admitted with encephalitis. The nurse should first assess the patient's A, pupillary response, B, level of consciousness, C, blood glucose level, or D, airway patency. Okay. This is going to be airway patency. So everything else is important, but not for the key word here is first. So think ABCs, airways first. Encephalitis is going to cause or can cause a rapid neurologic deterioration and decreased level of consciousness. And in that case, you want to make sure their airway's patent. Along with that, you're going to want to check their level of consciousness, pupils, and all that. But ABCs, what's first? Airways first. A 16-year-old intubated patient has a RASS score of 4+. The nurse should expect the provider to order what medication? Precedex, Versed, Ativan, or Sublimase. So they're intubated. 4+ means pretty high on that agitation and sedation scale. But the drug of choice is going to be Precedex. So again, delirium is a hot topic right now, and benzodiazepines have been shown to induce and increase delirium. So they're no longer recommended. You'll see us starting to go more and more away from Versed drips and stuff if we can use a Precedex drip instead. So It has analgesia effects, sedation effects without compromising the respiratory symptoms, so it's the preferred drug here. A nurse prepares the patient for rest by clustering care and low lighting in order to prevent A, agitation, B, sedation, C, hypnosis, or D, delirium. And again, this is delirium. So we cluster care, low lighting. We're trying to not interrupt their sleep cycles, circadian rhythms as much as possible. And all of that has been shown to allow for more continuous sleep and prevent delirium. Which of the following is the most important factor implicated in pediatric suicide? So A, identification as gay, lesbian, or bisexual. B, lack of social support. C, an active psychiatric disorder, or D, a family history of depression. And the most important is an active psychiatric disorder. So again, some kind of diagnosis of depression, bipolar, psychosis, substance abuse, or conduct disorder. All the other things can contribute to that if they have those, but that's the most important factor. The nurse is caring for a 14-year-old patient who is day 1 post-op resection of a brain tumor. Which of the following should the nurse report immediately? An end tidal of 35, a CPP of 40, mean arterial of 75, and systolic of 120 to 130. So this is going to be the CPP. This has the normal range of 40 to 60, but as we talked about in previous things, for infants, you want it above 50. Adults, adolescents, you want above 60. So a CPP of 40 is not enough for a 14-year-old patient. Which of the following cerebrospinal fluid results is indicative of bacterial meningitis? So A, glucose of 90, B, white cells of 200, C, red cells of 3, or D, protein of 120. So this is going to be protein of 120. So protein, again, I think the normal is like 10 to 30. 20 to 40. I don't remember. I'll have to go back and look, but it's, I think, somewhere less than 30. So a high protein level indicates bacterial meningitis, low glucose level bacterial meningitis. This is the one where I was talking about. This obviously is counting differently than the one reference I had for the chart before, but this high protein level indicates bacterial meningitis. Okay, this is a musculoskeletal question, and we didn't exactly go over it, but let's see if you can kind of just think about, normal pediatric musculoskeletal care to figure out the answer. So, children with achondroplasia may require osteotomies of the leg bones. When A, during infancy before walking occurs, B, if leg bowing causes pain, C, when leg bowing inhibits the ability to walk, or D, once full growth has occurred. So achondroplasia is a type of dwarfism, and they often do have bowing of the legs and do sometimes require surgery. So an osteotomy is cutting into those bones to kind of remove certain parts, help straighten out the legs. But the important part of this is you want to make sure you wait to once full growth has occurred. Again, this is in dwarfism, but in general in kids, you don't want to do surgery on their bones until full growth has occurred because you don't want to interrupt the growth plates. A child is diagnosed with Guillain-Barré syndrome. It would be imperative for the nurse to inform the provider after observing which of the following: A, increased hoarseness, B, weak muscle tone in the feet, C, tingling in the hands, or D, weak muscle tone in the legs. Okay, this is going to be increased hoarseness. So again, Guillain-Barré is that symmetrical ascending paralysis. So you're going to carefully watch for things that are indicating respiratory changes. So changes in their swallowing, hoarseness is going to be a sign their vocal cords are becoming weak and flaccid, and they may need intervention to protect their airway. A patient is admitted with a temporal lobe skull fracture. Temporal lobe. Which type of hematoma should be suspected? A, acute epidural, B, chronic subdural, C, acute subdural, or D, subarachnoid. Okay, acute epidural. So again, skull fractures are often seen with epidural hematomas. Approximately half the patients with an epidural hematoma have some kind of associated skull fracture. A nurse finds a 12-year-old patient with a postoperative spinal fusion to be restless and diaphoretic. The blood pressure is 110/80, heart rate's 120, oxygen sats are 90. Lab results reveal an H&H of 11.8 and 32. A primary intervention for this patient would be to adjust the settings on the PCA pump, transfuse 1 unit of PRBCs, obtain capillary blood gas, increase the FiO2. Okay. All right, so this is adjust the settings on their PCA. So a post-op spinal fusion is going to be very painful. They're going to need good pain control. And if the patient is restless and diaphoretic with a heart rate of 120, they're likely in a lot of pain. Their H&H isn't that bad. It doesn't need a PRBC. Their SpO2 is lower at 90%, so you could need oxygen, but likely what's happening is they're not wanting to take big breaths because of the pain from the surgery. So you're going to want to get their pain under control, and that should help with everything else. Okay, which of the following actions would be appropriate after the administration of DDAVP to a patient with diabetes insipidus? A, decrease the glucose intake, decrease the IV fluid rate, maintain the current IV fluid rate, or increase the sodium intake. All right, for this, you're going to want to decrease the IV fluid rate. So in diabetes insipidus, they have very high urine output. They're dumping a lot of fluid, and we're giving them a lot of fluid to compensate. So once you give them DDAVP or give them desmopressin, it's going to decrease their urine output. They're going to hold that fluid in. They're not going to need us to give as much to them. So you can turn their IV fluid rate down. Okay, a patient being treated for DKA is severely hyperglycemic. The serum glucose level decreased within the last hour by 150. The patient is receiving an infusion of insulin at 0.05 units per kilo per hour, along with an infusion of normal saline. Which of the following changes to the patient management would the nurse expect? Infusion of sodium bicarb, an increase in the insulin infusion rate, the addition of 5% dextrose infusion, or a reduction in the insulin infusion rate. So this one, it's going to be the addition of 5% dextrose. So it dropped by 150. That's more than that max of 100 per hour that we want to see. And so we're going to add in dextrose. The initial reaction might be to reduce their insulin rate, but unless the glucose rate has dropped way more severely than that or to a dangerously low level, we're not going to change their insulin rate. Usually in DKA patients, we do not titrate their insulin. You keep that the same. Even when their glucose starts to normalize, and we've added glucose in again because they're getting less than that 300 or 250 range, they could be on full D10 fluids and an insulin rate, and we're still leaving it there even though their glucose levels are then, in the normal, maybe, 120 to 150 range. And that's because the main goal of the insulin therapy, it is to decrease the glucose rate, but we want to decrease the glucose to get it into their cells to have them use it and to stop ketosis. Ketosis is what's causing the problem. It's causing that byproduct of ketones and the acidosis in their blood. So we need to stop ketosis. So you do not want to adjust or titrate or decrease the insulin rate until they're out of ketosis, and you tell that by urine ketones and blood ketones. So for this patient, adding in the 5% dextrose is what you're going to do. The patient's schedule for surgery. During the pre-op assessment, the nurse notes a history of poor weight gain, fatigue, muscle weakness, and hyperpigmentation of the face. Lab values include a serum sodium of 130. So the nurse should anticipate increase the DDAVP, increase synthroid, increase calcium dose, or increase hydrocortisone. So this one, the poor weight gain, fatigue, muscle weakness, hyperpigmentation of the face, that's kind of your key there, and then hyponatremia, low sodium level. Again, this question, like many other questions, they're going to give you lab values, they're going to give you numbers, they're not going to tell you normal, so you're going to have to know what's normal. But for this one, all those things together say Addison's disease, which is adrenal insufficiency, a lack of adrenal hormones, including cortisol and aldosterone. So these patients are going to be on maintenance hydrocortisone doses, and they're going to need increased hydrocortisone doses whenever they're going through something they need a stress response for, like illness, surgery, things like that. All right, and that is all of our questions. I appreciate all of you who are watching this recording. Hopefully it's helpful. I know it's a lot of information to go through. Next week, Tuesday the 15th, we're going to do session number 5, almost to the end. So session number 5, again, we're going to be going through GI, renal, hematology, and skin. And then session 6 the following week is going to be multi-system, so everything else that we haven't done yet. And I hope to see you guys then. Thank you so much for joining me for this one, and I will talk to you next week.